Respected panelists, dear audience, very good morning to all. It's my great privilege and honor to talk in front of this learned audience. I am Dr Saurav presenting a case of left main PCI in a patient with multiple comorbidity. My patient, 65 years, from Chittagong, presented with chest pain on minimal exertion, shortness of breath, and OHA class 3 to 4, orthopnea and palpitation. He was diabetic and hypertensive. He has got history of non-STMI 6 months back when he developed acute LVF and cardiogenic shock, and at that time gradually improved over time with medication. He was advised to do coronary angiogram at that time, but he refused. Patient has got history of carcinoma larynx, for which he was treated with laser microsurgery. Laser microsurgery, chemo, and radiotherapy 1 year back, no residual disease activity noticed. But for the last 15 days, symptoms were worsening, both angina and heart failure symptoms. So he came for further evaluation. On evaluating the patient, we found that the patient has got multiple risk factors and comorbidity, including obesity, hypertension, now presented with hypertension, uncontrolled diabetes mellitus, low ejection fraction, anemia, AKI CKD, diabetic foot ulcer involving the right heel, cellulitis of right upper limb, and history of carcinoma larynx, which was treated with chemoradiotherapy and dyselectrolytemia. So, including all those comorbidity and risk factors, we at first control the infection, control the diabetes, and then advise the patient for coronary angiogram. Here is the ECG at initial presentation showing widespread ST depression and ST elevation in AVR. So after motivating this time, patient was eager to do coronary angiogram. This is the angiogram findings. 50% stenosis proximal to mid and distal segment of the RCA. Left main 95 to 98% stenosis in distal segment involving origin of LCX and LED with thrombus in situ. LCX 60 to 70% stenosis in proximal segment, 99% diffuse in distal. LED also shows 80 to 90% diffuse narrowing in proximal to mid and distal segment. So, if we think this is a clean-cut case of triple vessel disease with left main involvement with thrombus in situ, we keep the patient on anticoagulation, and according to the high syntax score, uncontrolled diabetes mellitus, left main involvement, we advise the patient to do the coronary artery bypass grafting. We send the patient to CVG center, but patient was deferred at the center because of comorbidity and heart failure symptoms. So patient again came back after 2 weeks in our center, and he was not eager to do the CVG, but his symptoms were worsening. He was getting rest pain, especially at night. So was eager to do some solution of that. So we told the patient about all the risk factors, but patient were eager to do the PCI. So took the patient to cath lab. Guide catheter SPB 7 French was introduced. BMW guide were introduced into the LED, and pre-dilation with 2 into 15 millimeter balloon was done into the left main to the proximal LED. LCX were cyan blue were introduced, and then left main stent was deployed. It was 3 into 20 millimeter drug-eluting stent involving the left main to proximal LED. Then we recrossed the wire into LED and LCX, put the BMW in LCX and cyan blue in the LED. Then we did the post-dilation with 3 into 12 millimeter balloon. And after post-dilation, it shows that there is good flow. And then we did the pot with 4 into 8 millimeter balloon. After pot, it shows that there is significant stenosis at the distal part of the left main to LED stent. So we decided to do dilate the lesion and put a stent over there. We pre-dilate the mid to proximal LED with 2 into 15 millimeter balloon. Then we tried to put a stent, but it was occluded in the proximal part. Then again pre-dilatation in the proximal part done by another balloon. Then we finally were able to proceed the stent through the lesion and put the stent into the LED, involving the distal part of the left main to LED stent. And post-dilation using 2.5 into 12 millimeter balloon was done. So after post-dilation, this is the final result showing TME3 flow in the left main and LED. So after 3 days of the procedure, if you see the ECG, initial presentation ST segment was resoluted, patient was free from symptoms, And we did the procedure around 2 months back, and patient is now doing well. Thank you all.